So thank you very much for the opportunity to present. My name is Faisal Sharif. I'm an interventional cardiologist in Galway University Hospital in Ireland. These are my conflicts. So I think having listened to the two great talks, I think you have set the scene for pulmonary artery pressure to be now adopted widely. I think we've seen great presentation from Dr. Adamson, who just mentioned and discussed about the hemodynamic congestion. And I think we have seen significant clinical benefit over the last 6 years with more than 100 peer-reviewed publications in the space of pulmonary artery pressure monitoring and its outcome. And I mean, it's no doubt this is the biggest growing heart failure population, and it is without doubt an unmet need that needs to be resolved and has significant impact on quality of life and economic impact on the hospitals and the health services in general. And acceleration of telemedicine, I think, has grown phenomenally, especially in the context of COVID-19. I mean, I was talking to patients who are not even cardiovascular and Parkinson's disease and neurology, and everybody's now using virtual platforms to get themselves treated. So there has been a big acceleration in telemedicine adoption. Talking about endotronics Cordella Heart Failure System, it has two very distinct parts. Number one is the Cordella Heart Failure System, which is a non-invasive part where it allows us to do daily assessments of blood pressure, body weight, oxygen saturations, heart rate, ECG, and symptoms. And I think that's the first thing that we ask our patients to use. It allows that relationship to build up between the patients and the physicians. And I think it is really a trend-based management. And this part of the system is a commercial product, which is now available and can be used for any class of heart failure from 2 to 4. And the second part is really the Cordella PA Sensor system, very much what we talked about earlier with the CardioMEMS, and it allows us to do daily pulmonary artery pressure readings and gives insights into the decompensation earlier on, so we can intensify the treatment before patient is presented to the hospital. From the patient's, on the physician's perspective, it really empowers us to provide a differentiated care in the management of heart failure. We talk about comprehensive management, which can be a guideline directed in terms of titration of medication. We can very proactively lower the pulmonary artery pressures to the target range to reduce hospitalizations. And of course, the next step for us is to understand the impact or the outcome that we can have from ambulatory pulmonary artery pressure monitoring, which is quite complex in terms of its treatment. And I think we are now looking at exercise pulmonary artery pressures, and we would intend to add in cardiac output and stroke volume as we learn more about this. So Cordella PA Sensor system is slightly different to the CardioMEMS. I think we have the MEMS technology, but the placement is in the right pulmonary artery rather than the left pulmonary artery. And the sensor is delivered, and I think we have delivered nearly 15 of these in our patients. It's at the early stage of its development, and it's been very stable. We have a stability sheet that allows me to image the sensor before I implant it with some contrast injection. It has its markers and it's a very stable placement. And also the stability sheet allows us to do a fluid-filled pressure measurement while straight after the placement of the sensor. The reader is handheld, so the patient can put it on their chest. It's an anterior implant, and patient can check their pressures straight away after the implant is placed. It allows us to do pressures in different positions, standing, seated, or even supine. And the calibration equipment that is used in the cath lab is a very straightforward step-by-step guidance for calibration. So as I mentioned here, the sensor is placed in a target zone, which is well defined and is determined before we place the device. We do a pigtail and do a contrast angiography, identify the right pulmonary artery branch, which is usually A10, and place the sensor. And if you follow the steps, it has very little embolization of movement during or post deployment. You can identify and see it in cine angiography, and gives you a very stable anterior position and allows you to have calibration and very automated calibration with a fluid-filled catheter. There's an active clinical program ongoing. I think we have completed the Sirona first trial, the first in human trial, which was the safety and efficacy at 90 days for 15 patients, which is now published. We're now looking at a proactive IDE clinical trial in the United States with 970 patients with class 3 heart failure, over 90 sites in USA. And there is an active European trial, Sirona 2, which is a CE mark trial ongoing in 7 European sites. And a lot of those patients are nearly coming to the end of it. So the trial is nearly finished as we speak. I think talking about the device from my own perspective in Galway, it has a very patient focus. There is a huge compliance. 92% of the patients are responding, engaging with the clinical staff. We're getting information on a daily basis. Patient is, in fact, one of the beautiful thing about this is the patient is a part of the treatment, and they are part of the team that provides the treatment, and there is very active engagement and change in their medications. The care that we're looking at is the trend-based. So we have baseline pressures of these patients. We correlate them with their symptoms, and we see how the trend is changing over time. And we can remotely monitor this patient, especially when they're high-risk patients in a COVID-19 environment. The continuum of care is really, as I said in the previous slide, that we have a non-invasive assessment. And non-invasive assessment allows us to identify patients and funnel them into patients who would be suitable for the implant. So it's really a continuum of care from non-invasive to invasive, and allows us to do a guideline-directed therapy. So really, I'm going to finish here that it's really flip reactive care model from just being reactive. I mean, it's very proactive heart failure management, driving pulmonary artery pressures down. It's comprehensive because it has the non-invasive and the invasive part, and I believe it's a very friendly, user-friendly design that allows patients to engage and very easy for them to use. So thank you very much.